Good day, and welcome to the session on drivers of stunting reduction, where we'll present case studies from the Exemplars project. My name is Robert Black. I'm a professor at the Johns Hopkins Bloomberg School of Public Health. I'll be moderating this session, co-moderating with Dr. Mira Shekar, who is Global Lead Nutrition at the World Bank. As has been illustrated in other sessions in this conference, the prevalence of stunting has been slowly declining in many of the low and middle income countries of the world. But the decline has been faster in some countries than others. What can we learn from these countries that have done better than one might have expected? This is the subject of this session, the so-called exemplar countries that have done better in stunting reduction. First, we're going to hear from Professor Cesar Victoria, who is from the Federal University of Pelotas in Pelotas, Brazil, who will describe the current global trends in stunting and inequities. Following this, we'll hear from Dr. Emily Keats from the Center for Global Child Health and the Hospital for Sick Children in Toronto. She will provide the approaches and methods that will be have been used in the exemplars case studies. Finally, Professor Zulfi Bhutta, also from the Center for Global Child Health and the Hospital for Sick Children, as well as the Aga Khan University, will provide the results and the recommendations that come from these case studies. I'm going to begin with Dr. Victoria. If you could start your, Cesar, start your presentation, please.
Yeah, okay. All set? Okay, we all know that stunting is falling rapidly in some countries and not so rapidly in others. These are the UN global figures, and they show that stunting went down from 32% of children to about 20% from the year 2000 to 2018. But we want to take a different look at stunting reduction. First, we want to look at the coexistence of stunting and wasting, and we analyzed 50 countries with two DHS or mixed surveys around the year 2000 and 2015. We see that the presence of both stunting and wasting in children in low-income countries went down from 7% to 4.7%. Prevalence of stunting alone in these 50 countries went down from 40 to 31.9. There was less progress on the right-hand side, which are the middle-income countries. But when we have stunting in a population, the whole curve of height for age is shifted to the left. So I did the same analysis looking at the whole distribution of children. Let me take this slide apart and show you a bit at a time. Number one, this is a WHO growth standard. And we used a -2 Z-score cutoff to signal the presence of undernutrition, but it's a perfectly bell-shaped curve, a normal curve. When we look at low-income countries where they were in 2000, the red line in 2015, the whole population is largely displaced to the left, which means that not only children who are below -2, but also the ones who are above -2 are suffering from some kind of undernutrition. Therefore, looking only at those below the line, it doesn't give you the full picture. There has been some progress. The blue line is a little bit closer to the right than the red line. And when we also plot the middle-income countries, we also see that there's been some progress, and we see that middle-income countries' children are better off. All the curves, low income, middle income, they're wider than the WHO normal curve because of within country inequality. The scales in this graph is very tight. So let's look at another way. Here we have, the growth faltering in relative terms by age in months. We know the importance of the first 1,000 days. A lot of faltering happened within the first 2 years of life and prenatally. And this is what we get in low-income countries. So the figure is a little better now. We see that there's a little change in length at birth from 2000 to 2015, but the period of linear growth faltering is shorter. So children end up being less stunted than they would be 15 years ago. In middle income countries, we get a similar pattern, but then there's also an improvement in length of birth. And in all slides, you see that middle income countries have much less growth faltering than low income countries. However, there are also important differences within countries. And in this slide here, I show you the poorest 10%, the poorest 20%, the poorest wealth quintile of children in low income countries, and also the top wealth quintile in the same countries. And those children in the wealthiest quintile are longer at birth, and they show less intense and shorter growth faltering than those in the poorest quintile. When we superimpose the middle income country data here, we also saw differences. Children in the poorest quintile, they are more likely to falter and end up being close to children in the wealthiest quintile in the low income countries. So we are seeing now here systematic differences between low income and middle income countries. We are also seeing systematic differences within countries according to how poor or how wealthy the child's family is. These are implications that have to be taken into account in the exemplar study. And I'll hand over to Emily now, because this gives you the background for some of the analysis that will be shown in the next slides. Thank you very much.
Thank you, Cesar. That was great. Emily, over to you. I know you're going to talk about the methods that the exemplars group has used. So over to you, Emily. Thank you.
Okay, great. Sorry about that. A couple technical difficulties on the back end. I am going to be talking about the methodology and the approach of the stunting exemplars work, and I'll go through the results of one of our case studies, Ethiopia. So to begin, the broad stunting exemplar study objective was really to understand the major determinants of stunting prevalence decline in exemplar nations, and I'll go over what an exemplar is in a few slides from now. To steer us along in this process, we assembled a technical advisory group that is comprised of several experts across a range of fields, including nutrition, child health, health equity, economics, and they're pictured on the slide here. And this group has been really instrumental in guiding us throughout the life of the project. So in order to select countries for study, we applied a very systematic approach where we aim to identify true exemplars. And these are countries that have reduced stunting prevalence beyond what would be expected based on economic growth alone. So to select countries, we plotted the change in stunting prevalence along the y-axis against the change in GDP per capita along the x-axis. And then using this kind of a plot that you see on the slide, we could identify those countries that had either steep declines in stunting rates over time or high reduction in stunting prevalence relative to increase in GDP. So these are countries that are located below the line of best fit and preferably in the bottom left quadrant of the figure. The shortlisted countries were then deliberated upon among the tag, and they considered a few additional factors, including the country's total population, and we set a minimum threshold of 5 million, a variability across income bands and geographic regions, country security and feasibility of in-country activities, and then the existence of local contacts, potential partners, and also good quality data. And so applying all of this criteria, we ended up selecting 5 exemplar countries to study in phase 1 of the research, which are highlighted in red. We looked at Peru, Nepal, Kyrgyz Republic, Senegal, and Ethiopia. In terms of methods, we wanted to be really holistic in our approach to understanding the determinants of stunting, given that it's such a complex outcome. And so we used mixed methods to accomplish this. We started with a systematic literature review of peer-reviewed and gray literature, and here we essentially tried to synthesize information on contextual factors, interventions, policies, programs, anything that would have contributed to reduction in stunting in a given country context. We then undertook quantitative analyses, both descriptive and advanced analyses that I'll go through over the next few slides. We also undertook qualitative analyses, and these consisted of both national level and community level in-depth interviews and focus group discussions, including focus group discussions with mothers, in order to better understand the various perspectives of the nutrition evolution in a country. We assembled a timeline of key direct and indirect nutrition policies and programs using an iterative approach with our local partners and key stakeholders. And we attempted to create an outline of financial allocations, actual disbursements, and budgets and expenditures of nutrition-related policies, programs, and interventions. And then lastly, we used data from each of these exercises to derive and contextualize key findings. So this is a busy slide. I'm not going to go into the quantitative methods in too much detail, but essentially this summarizes the methods that were applied for each case study. And in brief, we performed equity analyses whereby we disaggregated national stunting prevalence by wealth quintile, maternal education, urban versus rural residents, and child sex. And of course, we also looked at the geographic distribution of stunting at a subnational level. We perform more advanced equity analyses as well, using the slope index of inequality and the concentration index. To quantify the change in stunting prevalence over time at the subnational level, we use both the compound annual growth rate and the average annual rate of change. So these just allow you to assess the relative change and the absolute change in stunting prevalence over time. We also looked at the change in linear growth, or HAS. And to do this, we used Victoria curves and kernel density plots. I'm going to show you an example of a Victoria curve in a few slides. But essentially, it is the predicted HAS score plotted against a child's age in months. And the kernel density plots produce smooth curves, which depict the entire distribution of HAS for the under 5 population for a given survey year. So you can see how mean HAS has changed over time. And we also undertook 2 sets of hierarchical multivariable analyses. So these use complementary approaches to answer the same question, which is what are the main predictors of the change in child linear growth over a given period of time? The linear multivariable regression uses a difference in difference framework, where you look at the time covariable interaction, and this allows you to assess whether change in a proposed predictor leads to change in HAS over time. And then the Oaxaca blinder decomposition is based on the same set of individual and household level data, but we tend to add ecological variables into the model. Here, regression models are used to derive beta coefficients, and these represent the association between a determinant and HAS. And then the beta coefficients are multiplied by the difference in the weighted means of the explanatory variable at the 2 time points, so the start and the end of our study. And this allows us to obtain predicted change in HAS as a result of the determinant in question. Our conceptual framework, I'm sure everyone is familiar with this framework. It's based off the UNICEF framework for undernutrition. And you can see that our determinants are grouped in different hierarchical levels depending on their proximity to the outcome. So those that are basic are furthest away from the outcome, and those that are immediate are closest to the outcome, things like diet and disease. And I just wanted to make the point here that for each of our analyses, we aim to consider indicators or proxy variables that would fit into each of these boxes. So determinants that we felt theoretically should have contributed to stunting decline in a given country context. Now switching gears a little bit, I wanted to go through the results from one country example before Zulfi takes over. I'm going to focus on Ethiopia, which is the dark blue blackish line, where you can see stunting has declined quite significantly from close to 70% in the 1990s all the way down to under 40% in 2016. In terms of country context, Ethiopia is a very large country of 109 million. It has diverse terrain and a population that's about 80% rural. The maps in the center are showing the subnational stunting reduction between 2000 and 2016. And hopefully you can see that although gains in stunting weren't uniform across the country, with some regions improving faster than others, what you'll notice is that overall the entire country did experience significant improvement by 2016. And in terms of other indicators and outcomes that are listed on the right-hand side of the slide, we see some variability. So for example, maternal mortality, still quite high, though it has declined substantially since 2000. But generally we see trends are going in the right direction. And so these are the Victoria curves that I mentioned. Each line represents a survey year, and we have HAS scores on the y-axis and child's age in month on the x-axis. So these really allow us to see where and when growth faltering is occurring. There are two crucial features to undernutrition that are highlighted through these curves. The first is the curves of y-intercept, which reveals the intergenerational susceptibility of a child undernutrition, or the extent to which a mother's nutrition could lead to small babies at birth. And then the second is the postnatal growth faltering process. And this is usually steepest between 6 and 24 months of age, which encompasses a child's first 1,000 days of life, at which point it tends to taper off. So the idea is that you can compare the shape of the various curves, and this will indicate where improvements or non-improvements have been made in maternal and child nutrition. So the first thing you may notice when you look at these curves from Ethiopia is the jump in the y-intercept after 2000. So if you compare the blue line at the bottom to the yellow or the green curve, which is 2011 and 2016. And this is demonstrating improvements in maternal health and nutrition. When you look at the curve from 0 to 6 months, you can see that it's flattened out quite substantially if you compare 2016 to the earlier time points. And this is suggestive of positive or improvements in breastfeeding practices. Again, a slight flattening of the HAS slope is seen for the 6 to 23 month period. This is indicating there could potentially be improvements in complementary feeding practices and disease management and potentially household environments as well. And then you might note that the children at 24 months, the green curve, are significantly taller and healthier in 2016 when you compare it to the blue curve, those children in the year 2000. And finally, this slide shows the results of the decomposition analysis along the bottom, along with some critical points from the policy program and the qualitative work. The percentages essentially indicate the contribution of a factor or several factors that have been grouped together to child stunting decline over the period in Ethiopia. And what you'll notice that the biggest contribution came from agricultural investments, strengthening, and improvements. 32% of the decline in stunting in Ethiopia can be attributed to improved consumable crop yields, which increased household food security and we think improved individual dietary intakes. We found that health system strengthening, and particularly around expanded access to services through health extension workers, was the next most important factor, contributing 28%. And then thirdly, WASH policies and programs, and specifically community-led programs, reduced open defecation, which was another major contributing factor to improved linear growth. Other important factors included economic improvements, improvements in education, especially for girls and women, reductions in fertility, and improvements in maternal nutritional status and maternal and newborn care. So the story overall in Ethiopia was really multi-sectoral, but with a major focus on agriculture, community-based interventions, and also resiliency in the face of frequent climate shocks. And with that, I will stop, and I'm going to pass the baton over to Zulfi, who will talk about the cross-country findings.
Thank you very much, Emily. That was great. While we wait for Zulfi to get his slides up and running, just a reminder to everyone who's listening on that you can post your questions on the link. So please do post your questions so that we can try and address those as we go along the session. Over to you, Zulfi. Thank you.
Well, thank you very much, Meera, and I hope that the slides are visible and visible in the screen share full screen mode. So my task has been made a lot easier by the preceding speakers who have given the background, and Emily has gone through the methodology in some detail. What I'm going to do is to principally go through the cross-country findings in terms of what we learned from across these 5 examples from phase 1. All of these have been published recently as a full supplement in AJCN. And as you can see here, the annual rates of reduction, compound annual growth rate or rate of reduction in stunting varied from anywhere like 2.5% per annum to about 6% per annum. What we do recognize, consonant with what Cesar was saying early on, is that in all of these countries, if you look at the height for age, Z-score distribution patterns, that there is a shift of the curve to the right. And you can see this pretty clearly in terms of the movement at the lower end, where is this stunted children moving towards the right of the curve. But you also see notably in some countries, not all, a change in the shape of the curve, that the curve becomes a lot narrower, which generally indicates a reduction in inequities across the distribution patterns for linear growth in this population. When you take these 5 countries and compare the Victoria curves, which are their growth patterns from serial surveys, and here you have the first and the last survey for each country, you see very clearly that these are very different over this period of time. And there has been a lifting of every country in terms of their growth patterns. You also see quite clearly here that in some, not all, there is also a change in the intercept, which represents an improvement in the status at birth, and linear growth as represented by length in the first few weeks of life as measured. You also see that the pattern does reflect both a change in the early part of infancy, but also in growth patterns later on in childhood, which could be a combination of improved feeding and disease management. We were able to analyze across all of these countries patterns of inequities, and you can see for all of these countries that there is a change in urban-rural gaps, more notable in some than others, but it's discernible that those differentials did reduce. You also see an improvement in terms of the gaps by maternal education pattern, that the highest rate of stuntings were in those without any education. And over time, that does go down as stunting rates improve in all of these countries. You also, to some extent, see a pattern emerging from looking at asset or wealth quintiles, but it's not necessarily in the direction that we would intuitively expect. So let's take these first 2 examples. Peru, between 2000 and 2016, not only a significant improvement overall, but a reduction in the gap. So the highest rate of reduction in stunting was actually in those who were in the poorest quintiles. Similarly observed in Kyrgyzstan, with a notable reduction in the inequity gap that exists in these countries. But if you look at this overall, not all countries achieved this gain in stunting by a reduction in inequities. I've given you the 2 examples of Peru and Kyrgyz Republic where this happened. But if you take the other 3 exemplars, Ethiopia, Senegal, Nepal, that we looked at, inequities actually increased in quantitative terms. And what that means is that maybe there wasn't sufficient targeting. And if anything, the policy message in here is that these countries could have potentially gained a lot more in terms of change had there been, in addition to the overall reduction, also a focus on the ultra-poor or those who were marginalized. Now, we undertook, as Emily mentioned, a range of qualitative assessments and policy reviews in each of these countries. And this slide summarizes some of the strategies that were evaluated through national expert perspectives, health system strengthening, agriculture, food security. And while broadly many countries had improvements and gains which were endorsed by these stakeholders, as shown in green, in some instances, this wasn't mentioned at all. You also see this in very specific nutrition actions, whether it's breastfeeding, complementary feeding promotion, food fortification, that this does seem to be a more uniform, homogeneous mix across these countries, with strategies making sense to country-level stakeholders. A very important group that we talked to in 4 of the 5 countries were the mothers and the grandmothers, reflecting their own perceptions over a period of time where these policies had been implemented. And as I had mentioned earlier on, this is over the last 15 to 20 years in most of these countries that we reviewed at. And there was some context and content validity here in terms of people recognizing the contribution of various initiatives, both for poverty reduction, education, women's empowerment, and notably for water sanitation hygiene in terms of their potential contribution to overall improvements in health and nutrition in a given population. So this is a stakeholder perspective, including importantly, the recipients, the mothers and the grandmothers. When you put it all together and you look at what initiatives and strategies largely drove stunting decline based on the qualitative and quantitative assessment, you begin to see a pattern emerging with these 10 categories that you see highlighted in this particular table. And they do reflect a common mix of investments and initiatives that cover several dimensions, such as education, focusing on population growth, food insecurity, and living conditions, and also importantly, some direct health and nutrition interventions. But these are qualitative. These are things that you get out of stakeholders in terms of asking them what, in their opinion, mattered and what was readily recognizable through government's initiatives. Is there any quantitative or, let's say, more objective information from the data available? This might be the case. Emily mentioned to you the Oaxaca blinder decomposition analysis, and this is the decomposition analysis across all of these 5 countries. And as you can see, these countries are different. You have a very high contribution of economic improvements and gains in countries like Kyrgyz Republic, and you have a contribution of other things such as agriculture or population movements from food insecure, high mountain households in Peru, and so on and so forth. So this does reflect a little bit of a mixed picture. And when you put it all together, what is clear from our assessment is that you require both direct and indirect health sector interventions, shown here with a very important and consistent contribution of reduction in fertility, family planning to be exact, and also gains come out of other sectors, such as education, water sanitation, hygiene, etc. So to summarize our cross-country findings, ladies and gentlemen, these countries did demonstrate best practices in program implementation, and at least some of them targeted inequities. In all of them, appropriate data collection, monitoring, and evaluation was important, with notable multi-sector collaboration. But it's important to underscore that none of these had a stunting specific program. Their programs were generally around nutrition support and reduction of extreme poverty. And it contributed to a large extent through these non-health and nutrition sector interventions to about half of the change overall that we see in stunting reduction. Very importantly, we do see contributions from maternal and newborn healthcare proxies that we have available within these data for these. Maternal nutrition status and birth outcomes as reflected in linear growth at birth, and an important contribution of education. So we tried to put this together as a 10-step process that might help guide countries. And this is something that we have now beta tested in not only the first 5 countries that we evaluated, but in the subsequent phase 2 that I'll refer to in a minute. And it all starts with information, particularly granular subnational information that allows you to look at geospatial patterns of stunting and many of the drivers that affect growth in children, both stunting and wasting. We are very confident in stating that support for sectors outside of health, such as food security, reaching marginalized populations through social safety nets, education, reduction in gender disparities and empowering girls, and improvements in living conditions have a very important contribution to reduction in stunting. But also equally important are direct maternal nutrition and health interventions, and for the first time, a clear contribution across these countries of family planning over time. These are not inconsistent with the global guidance and many of the other investment frameworks that are available through the work of agencies, and notably the World Bank's investment framework for nutrition. And Meera Shekhar may want to speak to that shortly. So we do believe that our effort does not give you any necessarily diametrically opposite findings to what people have been saying, but it does help solidify and quantify some of those approaches through this mixed methods approach. We are now focused on going a step further, firstly, completing the analysis of some additional countries in phase 2, and they include Uganda. They also include a deeper dive into Ghana, and 3 large countries where we believe that we have subnational exemplars. where there are differentials between various parts of the countries, with some populations doing very well. And these include Pakistan, Nigeria, Indonesia, and importantly, a large subnational study in India. So I want to finish by just saying that I think this quotation by Dr. Brundtland, or many years ago, holds true today, perhaps more than ever, particularly in the context of the current emergency that we've been witnessing over the last 10 months or so. And what she said was that the dual scourge of hunger and malnutrition will only be truly vanquished when people's basic health needs are met and women are given their rightful role in societies. And I think one cross-cutting lesson from these country-level exemplars is that investing in women's health, education, and development and reduction in gender disparities holds a particularly important key for improvements in health and nutrition. Thank you very much for your attention. We'll be happy to take questions.
Thank you. Thank you very much, Zulfi. And thank you again to Cesar and Emily and to my co-chair, Bob Black. We will now move on to questions and answers. We've fortunately been on time. I would encourage everybody to continue to post your questions and we will try and respond to those. I'm going to take 3 questions and pose that to the 3 speakers, and then come back to you for more questions. So a few questions that have come up. One is a question from Pat M. and Fanny S. Very similar question from both of them around birth length, both in middle-income countries and low-income countries. And assuming that it could be measured, which we know it can be, would low birth length be an interesting indicator? That's one question. And related to that is that more of a comment that it seems that improvements in birth length continue in the first 1,000 days. So that's a question for you, Cesar, primarily. And then Jennifer asks a question, and Catherine D asks a similar question as well about maternal health. The question is primarily for you, Zulfi. Maternal health, it seems, is contributing only 5% of the decline when the Y-intercept changed so dramatically. Was it that this variable did not include maternal nutrition status? And Catherine's question is on maternal height. What happened? What are the data on maternal height during this period? And then last question from Saul M, saying without any counter examples, that is countries that did not improve stunting. What is the reason for believing that these determinants are in fact causal and not just associations? So over to all of you for questions. Cesar first, and then Zulfi and Emily. Over.
Thank you. Thank you, Mira. Really good question on birth length. What we see is that generally human intrauterine growth is better at protecting length than protecting weight when there is maternal undernutrition. So we usually find that birth length is something like 0.5 standard deviation below the WHO curve in most countries, whereas birth weight can be much, much lower. So there's number one, it is protected. Number two, we do see small changes and improvements in birth length, as I showed in my analysis of 50 low and middle income countries. Fairly minor, maybe 0.2 standard deviation improvement. And also Zulfi showed some really interesting examples of the exemplar countries. Now, having said that, the use of birth length in routine services is complicated because it's not that easy to measure. And very, very often, measurement at birth is very poor. So this is what leads, it's much harder to measure than birth weight. So therefore, I think it's the main lessons we are learning are from surveys with standardized measurement methodology than from routine data, which, as I said, are really prone to poor measurement error. Thank you.
Great, thank you. Zulfi, over to you.
Well, thank you very much. Both the questions that you posed are great questions. Cesar has already addressed the whole issue of birth length and birth weight, and they are also tied to the data that we have on maternal nutrition. So unfortunately, some of the weakest things that we have in the panel data needed to do these analysis, which is basically, do you have a synthetic cohort that you could track, so-called between baseline and end line, with some measurements in between. We tend not to have good information on many things like gestational weight gain. Even on maternal height, we have not found major changes between the time periods in question over the last 10 or 15 years, although in cross-sectional data, we see consistent independent relationship between stunting and maternal BMI and maternal height. We looked at some of the proxies such as maternal age and age at first birth, and that does come out as we indicated, teenage pregnancies and also inter-pregnancy intervals. So one big question that has been posed is without a control group or a comparator, why should we believe that these are really important findings and not just associational? And the problem is that you truly cannot compare a country A with a country B, and we've tried that in several ways, because the policy dimension, the governance, the political landscape are so different that even if you try and match for 50 indicators, you still end up with a very imprecise and inaccurate comparison of a country A with a country B. But I think the strongest cases for counterfactuals are actually within countries, because you have at least some consistency at a federal level, if not at subnational level, in terms of what drives a particular policy milieu and governance and programs. And that we have seen in the large country examples that I just mentioned. For example, in Pakistan overall, you do not see consistent change in stunting over time at a national level. But when you go subnationally, you find that one of the poorest provinces and a relatively rich province, and not in the entire province, but at some regional level, have shown changes. And those subnational comparisons or counterfactuals are indeed more powerful. And just to persuade Swal that I'd be happy to share over time, we have just finished this, that the findings from those subnational counterfactuals are very consistent with those from our phase 1. And they are not just restricted to one country. We have now seen this in India, and we are undertaking this in Indonesia and Nigeria. So the point is very valid that we probably need additional counterfactual examples.
Great, thank you very much, Zulfi. Emily, anything you want to add, particularly on the maternal data question?
Not on them, but well, I was just going to add a bit to the third question that you posed around association versus causality, which I think is a really important point to raise. These are DHS data, and of course, you know, the data we use are imperfect, and the analyses themselves are imperfect as well. They each of them has different strengths and limitations to them, but I think one of the strengths of our analyses is the various components to the methods that we undertake. So we're not just focusing on that quantitative decomposition analysis, but we're triangulating findings across, you know, qualitative work, policy program analyses. So I think that does bring some strength to the work and allows more insight than just pulling out associations from like one DHS survey.
Great, thank you very much to all of you. And for everyone else who's participating, we are monitoring all your questions, so please continue to post questions online. And while we are reviewing the questions that are coming up online, let me add one question that I think is really important to think about as we go ahead. Sophie, as you said, this work will continue with additional countries. So one of the things to think about is what is missing from these analyses? What can be done better or differently? Any thoughts on that?
Yep.
And while we are thinking about that question, let me pose this other question from Mohammed B, which says, can these kinds of analyses also be applied to wasting? And if so, do you think we can find similar results at national or subnational levels? So,
So the
over
second
to
part is
whoever wants to take it. Yes, go ahead.
so others can chip in. Second part's easier. Yes, absolutely. If you can find true wasting exemplars, unfortunately, we find that the wasting story is a lot more nuanced and mixed compared to stunting. And some of the countries with significant gains in stunting actually have static wasting levels. So we are in our next phase of work looking at wasting as well in a few large countries. So more on that later. What data are missing? Now, if I had a wish list of the kind of data that we would like to see in these panels that we have looked at within countries, the one I've already alluded to, better data on maternal health and nutrition. So we have very indirect data through maybe status at birth. And as Cesar already said, we don't have good birth weight data. We have the first measurement, which generally is not even at birth, is a couple of weeks afterward. We take that as a proxy. Ideally, we should have better information on maternal nutrition through the lens of gestational weight gain, pre-pregnancy status, etc. We have some data on maternal anemia, but then again, better data on women of reproductive age as opposed to anemia in pregnancy and lactation. The most important thing that we lack is good dietary intake data. So we've had to use proxies in many places because if you go to household level information on dietary intake for women as well as for young infants and children, those kind of data don't exist. You have very indirect information on through food baskets at times and often not even that. So I wish that we would have been able to use some of that direct information rather than rely on proxies in terms of economic improvements affecting food baskets, the impact of social safety nets or cash transfers on better diet qualities. So those two things stand out, in my opinion, as major data gaps that I hope prospectively and in the future one can address. Emily, do you want to add anything?
Yeah, I'd like to add something just on the wasting bit, because I think it's an interesting comment and something interesting to think about in the work as we're moving forward. As Zulfi said, the methods are really flexible and adaptable, and you can apply them to different outcomes as long as there's really a story of change to tell. And so we've actually been thinking through in the phase 2 work, like what is a true exemplar? And maybe a true exemplar is one that has reduced stunting along with reduced wasting. And so we've started to factor this into our decisions of let's say, state selection. We're going to be looking at Nigeria in phase 2 work. And we're starting to think through doing a more in-depth analysis of different states, maybe one state that has reduced stunting but not reduced wasting, one state that has reduced both, one state that has reduced wasting and not stunting, et cetera. So I think it'll provide a lot of really important insights into what's going on at a subnational level, how the programs are working, where the bottlenecks are. And that is something that we're thinking about in the phase 2 work.
And ideally with the lens of long-term outcomes. So we are also looking at exemplars being defined as not only change over a shorter period of time with length and weight, but also those that have avoided the double burden of overweight and obesity in school-age children or young adolescents.
Great. Thank you very much, Zulfi and Emily. And thank you, Cesar, for the earlier comments. Just in closing, we have less than 3 minutes left at this point. Just to add a couple more things on the wasting issue, I think it's absolutely critical as we go forward that we look at that. The challenge there is no research available on preventing wasting. We have research and evidence on treating wasting, but we still don't have enough. So that's a huge gap as we go forward. In terms of what can we do differently going forward, I think, Zulfi, thank you for the data gaps that you highlighted. Those are critical, and I'm hoping that the researchers who are online can help us fill those data gaps. But perhaps the other thing I would highlight is that we need many more prospective analyses of large-scale programs that are managing to reduce both stunting and wasting in countries. So, and we have some studies ongoing in Rwanda, we have some studies ongoing in Cambodia, prospective large-scale programs. Cesar, any last words from you? Oh, sorry, and one other thing to mention in terms of going forward is that since you brought it up, Zulfi, is the issue around financing. We perhaps need to do a little bit more on the financing side to see what was financed and to what extent in future case studies. Cesar, last word to you.
Thank you, Mira. Just following up on what we haven't measured properly, following up on Zulfi and Emily's answers, I think we haven't really measured empowerment properly. In some countries where there were massive reductions in stunting, like Brazil and Peru, there was the huge multi-sectoral programs to empower communities and in particular to empower women. And that is really hard to measure, but that is one of the causes of better nutrition. So thank you very much. And thank you all for this excellent session.
Thank you, Cesar. Bob, any last word from you?
Only to thank the speakers and you, Mira, for a really interesting session. And I think we're close to running out of time, so nothing more from me.
Indeed. A big thank you to all the speakers and to you, my co-chair, Bob, and really to this fabulous audience that has engaged despite the challenging situation that we are all in. So thank you all very much. As you know, there is an Exemplars website as well that you might want to engage on. And Zulfi, I'm assuming you will share that.
It's very simple. Just Google Exemplars and you'll find
Google
it.
Exemplars and you will find the website. Please engage on that website as well. There will be lots more information coming in the coming months. So again, thank you, everybody. Good evening, good morning, good night, good everything. Good day, stay safe, and look forward to more sessions like this. Bye-bye.